In pediatric orthopedics, there's a lot of diseases you have to know. They're not really going to confuse one for another, but because there are so many and each of them have so many little nuanced details, it becomes challenging to get a hold of them all. We're going to go over only the high-yield diseases that you have to know. Let's start off with the hip. And what we're going to do is talk about each disease as it presents relative to the age of the patient presentation, and then some diagnostic steps you might do or therapeutic interventions. All right, and this is actually really easy to do. You basically only need to know the age of the patient and you can have the right answer, except for the wild card that comes in at the end. So let's approach these diseases in increasing order of age. The first is developmental dysplasia of the hip. This is going to occur in the newborn. And when you walk into the newborn nursery doing your well baby visit, you're going to do the Ortolani and Barlow maneuvers. And what you'll find is a click. Developmental dysplasia of the hip has a clicky hip. But a clicky hip can be just laxity. Babies have that. It may be completely normal. So you identify the click and you bring them back in 4 weeks. If the click is still there, that's not laxity, that is developmental dysplasia. So to diagnose developmental dysplasia of the hip, you're going to do the ultrasound. That ultrasound will occur at 4 weeks after there's a failure to resolve spontaneously. Because this disease is about the acetabulum growing around the femur, you want to make sure that that alignment is there so it happens. In a clicky hip, in developmental dysplasia, you may not get that. So the treatment for this is to put the kid in a harness, to line up the joint and the bones. The next in escalation of age is Legg-Calvé-Perthes disease. This is going to occur in a kid who's a little older than a toddler. Look for a 6-year-old. And this is avascular necrosis. So it's going to be an insidious onset of an antalgic gait. It's going to start off where he doesn't really want to walk. He's already learned how, but now he starts slowing down and then doesn't really want to put weight on that leg, and eventually he's going to completely protect it altogether. So insidious onset of an antalgic gait in a 6-year-old is likely to be Legg-Calvé-Perthes. And it's diagnosed with an x-ray. Once you find it, all you need to do is cast it. If you're a little older, in the teenage years, you might end up with slipped capital femoral epiphysis. Slipped capital femoral epiphysis occurs in kids who are going through a growth spurt or who are really fat. It is going to be a non-traumatic joint pain. Non-traumatic joint pain in a teenager undergoing a growth spurt, slipped capital femoral epiphysis. What you need to know for the test is that the type of x-ray you get is a frog leg x-ray. It's not enough just to say x-ray or multiple views, it has to be frog leg. And this is the only diseases we're going to talk about of the hip that requires surgery in a kid. Now, you can see the escalating age. If there weren't the wild card and that other one that's just like that wild card, you could do this on age alone. A septic joint may occur in any age child. And as we learned in adult medicine, if you ever have the suspicion for a septic joint, effusion and fever, you're going to do an arthrocentesis. And that arthrocentesis is going to show you greater than 50,000 white cells. If you have that, you need to drain it and give antibiotics. That person on the test who presents with a septic joint is going to be obvious. They're going to be toxic. You're going to see fever, leukocytosis, elevated inflammatory markers, ESR and CRP, and the inability to bear weight. These 4 things are the Coker criteria. You will not have to calculate a Coker score for the test, but know what it is when you see it on the wards. When it's obviously septic, you're going to tap them and give antibiotics. But the look-alike to septic joint, transient synovitis. Transient synovitis occurs at any age and generally presents with hip pain. It usually occurs after a viral illness. This is not reactive arthritis like we discussed in rheumatology, but has a similar concept. Viral illness, and then a couple weeks later, hip pain. But that hip pain may be really bad, so you might see the inability to bear weight. For transient synovitis, it's a clinical diagnosis and you do nothing but supportive care. Give some anti-inflammatories and come back in 2 days. It should be better in 2 days. The question you're going to run into is, do I need to tap the transient synovitis? So what you're looking for is the presence of the COCO criteria, things that say this person is actively infected, you need to do something about it. The more of them you have, the more likely you are to do an arthrocentesis. The less of them you have, the more likely you are to recommend supportive care. That's the hip. Let's move on to the knee. And that's going to start off with Osgood-Schlatters disease. Osgood-Schlatters may also be known as osteochondrosis. You may see on the test either the eponym Osgood-Schlatters or you might see osteochondrosis. This is going to present in teenage athletes. And the teenage athletes are going to have knee pain and tibial swelling. They may have pinpoint tenderness on the tibia. It matters because they're athletes, right? And the diagnosis being clinical, you can make the treatment choice right out the bat. The reason why it matters that they're a teenage athlete is because the treatment is to stop doing what you're doing. So you can just sit it out. That's going to be curative. Or you can just work through it. And if you work through it, you're going to have this palpable nodule in the tibia for the rest of your life. Now, if you're talking to a 16-year-old varsity athlete who's identified by their sports playing, it's going to be really hard to convince them to not keep doing what they're doing. But it's actually okay. Both end up being fairly benign. So likely the test question is going to be, what is the diagnosis, not how do you treat it, because the kid's going to make the choice himself. The next diagnosis is scoliosis. And this is a deformity of the spine. It is always going to present on the test as a teenage girl. And she'll either have moderate symptoms or severe. Now, scoliosis is a problem with the spine, but it's not kyphosis leaning forward or lordosis going back. Scoliosis is side to side. And usually it's to the right. Moderate symptoms are going to be cosmetic. She's always tilted to the right. Severe, though, if you get tilted far enough and the ribs start coming together, there's no room for the lung to expand, and you might actually present with dyspnea. The diagnosis begins with a physical exam maneuver called the Adams test. In the Adams test, you have her bend over, touch her toes. If one shoulder is higher than the other, it's a positive screen. Now, because it's a problem with bones, you'll be able to see the scoliosis with an X-ray. Treatment comes down to slowing progression and reversing the disease. If you brace the girl, you can slow progression and maybe escape surgery, especially in the case where it's really only a cosmetic deformity. Surgery with the placement of rods is required to reverse the disease and is usually indicated in someone who doesn't want to be crooked anymore or has that severe presentation. We have to talk a little bit about cancers of the bone. And there are two you have to know. And you can pretty much separate them out based on their location on the bone and their X-ray appearance. The two you have to know about are Ewing sarcoma and osteosarcoma. Ewing's is caused by translocation 1122. And you can remember that because 11 and 22 is 33. That's Patrick Ewing's old basketball jersey. Ewing sarcoma is also going to be in the mid-shaft, and the X-ray appearance will be described as onion skin. Onion skin appearance, mid-shaft, Ewing's sarcoma. they're going to actually show you an x-ray. And if you see a thing in the middle of the bone and that thing has a bunch of rings around it, that's going to be Ewing's. On the other hand, at the distal femur is going to be osteosarcoma. Osteosarcoma is associated with the retinoblastoma gene, and they may actually have had retinoblastoma on the first day of life. And you're going to look for a sunburst pattern. Sunburst pattern on the x-ray on the distal femur, retinoblastoma. Now both of these are going to present the same way. That is to say, there's going to be focal atraumatic bone pain. You see focal atraumatic bone pain because it's a problem with the bone, you're going to get an x-ray. And you're going to see either the onion skin or the sunburst pattern. You want to make sure that the diagnosis is right, so you can use the best radiographic test, which is the MRI. But because it's cancer, before you do anything with it, you want to get a biopsy. Treatment for both is resection. And I want to close with special considerations of fractures. We learned in adult medicine that there's certain times you need to go to surgery and sometimes where you can just cast. In kids, there's an extra consideration. So surgery means open reduction, internal fixation. And you're going to go to surgery if you've got an open fracture. That's effectively an infection that needs to be washed out. You need to go to surgery if you can't line up the ends very well. That is comminuted or angular. But now you also need to give consideration to the growth plate, because kids are growing. If you fracture the growth plate, even if it's fairly mild, you're going to end up with one leg that's shorter than the other. So if you have involvement of the growth plate, in addition to the usual things you consider in an adult, you still need to go to surgery. Now, of course, if you can, because all these things are negative, you want to cast. But just add on that extra piece about the growth plate. All right, to review all the diseases all at once. Diseases of the hip, developmental dysplasia, clicky hip, ultrasound at 4 weeks, harness. Legg-Calvé-Perth disease, age 6, get the x-ray, cast it. Slipped capital femoral epiphysis, teenager in his growth spurt, frog leg x-ray, do surgery. Septic joint, fever, leukocytosis, swelling, and the inability to bear weight, tap it, antibiotics. Don't be tripped up by transient synovitis, which might sound like these other diseases that occur after a viral illness, but has few to none of the Coker criteria. It's a clinical diagnosis and give them supportive care. If it doesn't get better, in 48 hours, bring them back. Osgood-Schlatters disease, palpable nodule, palpable pain, tibia, knee, just make the diagnosis, osteochondrosis. Scoliosis is the teenage girl who's crooked to the right. Get an x-ray, brace the slow, rods to cure. Ewing sarcoma mid-shaft, onion skin, MRI, biopsy, resect. Osteosarcoma, distal femur, sunburst, x-ray, MRI, biopsy, resect. And lastly, fractures of the growth plate must be taken to the OR. That is pediatric orthopedics. Become a better doctor. Subscribe now to get access to our premium content.